Second installment of our Southern California Emergency Care Conference this year. We're doing it a little differently because of the wonderful COVID-19. So doing them as a series of webinar. This is our second webinar in a series of 4. So I'd like to thank everybody who joined in. And if you haven't signed up for the other 2 coming, please check out our Facebook page at SoCal ECC on Facebook and get signed up for those. The way we're going to work this today is Dr. McGlung has joined us and is going to be giving his presentation, and then at the end we will shoot you a link for a quick post-conference survey, and then once you complete that survey, we'll gather all those email addresses and we will email your CEs out to you. So stay tuned for that. It's taken us about a week to get them out. I think the ones from last week just went out a couple of days ago. So without any further ado, we'll get into it. Dr. McGlung is a longtime supporter of our conference and an excellent speaker. Way back in February, when COVID was just getting ready to start rearing its ugly head, he put together an amazing presentation for the clinicians at Palomar on what we could expect from COVID and what we thought was coming around the corner. So I thought it would be a great opportunity for him to tell us how the reality lived up to the expectation and what we have coming to us. Dr. McGlung is board certified in emergency medicine, and he is the head of the training department for the Palomar Emergency Department. So we thank you very much for being here, Dr. McGlung, and without further ado, I'm going to turn it over to you.
Great, thanks, Steve. I really appreciate it, and thanks for the opportunity to speak at the conference again this year. So this topic is going to be what we've learned about COVID-19, and this is, as Steve mentioned, is a follow-up to a presentation that we did in I believe early March. And if any of you are interested or have trouble sleeping, you can go to YouTube and just type in Christian McGlung MD and find the video on that. So this is going to focus a little bit more on what we've learned since then. Obviously, with the novel virus like this and disease, there's a lot more that we needed to understand about it, and we are improving in our understanding, and the amount of literature that's coming out right now is significant. There are over 19,000 published articles now on the topic of COVID-19. It's overwhelming to be able to keep up with it and to maintain a summary of it. So at USC, we have a evidence-based summary that was being maintained up through August 7th, and then the authors basically became too fatigued in being able to keep up with it. And currently, the best data source is very difficult to navigate, but is through the Norwegian Public Health Agency, and has a live continuous map of published reports that you can look up things by diagnosis or by cause or by treatments and so on and so forth. And so there, every published report that comes out that meets a certain level of criteria is included in that database and is kept up to date daily. So with that being said, the objectives of this study are to look at the past models and our current trends, examine the evidence for current treatment guidelines. We're going to review the effects of the personal protective equipment, and also look at ways that we determine if someone needs to be hospitalized, intubated, or discharged. For full disclosure, I'm currently a principal investigator with AstraZeneca on a study of immune modulating therapy for COVID-19. I'm a co-founder of Seabooth Innovations, which is a diagnostic 12-lead EKG device company with patents, and also prior work as a data safety monitoring board with Medicine Nova for clinical trials on severe asthma exacerbations. I don't think that any of these particular issues here are influencing what I'm writing or presenting today, but I'm not, for instance, I'm not presenting anything specifically on immune modulating therapy for COVID. So back in March, the Imperial College London had put out this series of models representing what could happen with COVID-19 if we had no approach or no planned approach to mitigate its spread. And what they showed was that there was a possibility that in Great Britain, they would see as many as 510,000 deaths before June 20th. And that in the US, we might expect as many as 2.2 million deaths within that period of time. And it was important to underline that this was a model that was meant to demonstrate how things could spread, and this was with 0 measures being put in place. And so this wasn't necessarily a prediction of what would happen, it was a prediction of what could happen. And that's an important distinction to understand with what they were doing. They were showing what the maximum amount of spread could be within a short period of time. So what we've seen is, and you'll see here, they were looking at deaths per day and predicting in the US, deaths per day could reach over 15 deaths per 100,000 in the population. And that's how they calculated 2.2 million deaths within that time period as the total area underneath the curve there. So what we actually have is this, and this is from today. So current total cases in the US is 6.6 million. There have been 196,000 deaths in the US and 269,000 cases within the last 7 days. California here lists showing that that there are approximately 36 deaths per 100,000, and thankfully that 36 deaths per 100,000 is over the total period of observation and not per day. So really, if we're seeing obviously a fraction of the number of deaths that were predicted by the Imperial College London models, and that's because we've instituted mitigation policies to reduce the spread and improved awareness and information sharing, not just with the public, but across hospitals and across health institutions to identify what the best practices are and to mitigate all of our risk. And so when we look more closely at California, current, these again are from today, 766,000 cases. There were just 3,000 new cases today alone, and there have been 14,000 fatalities and deaths so far, and 106 in the past 24 hours. And so, again, these are remarkably low numbers in comparison to what could have been, and obviously, in comparison, when we go back here, in comparison to other states, we're leading with the most number of cases, in that Texas has 674,000, Florida with 663,000, and then a wide disparity with the next state being Georgia at about 300,000 cases. So, but as we've seen, we're seeing increasing rates of spread within the Southeast, and so we do expect those numbers to continue to increase as we do our own. So here in San Diego, this is from San Diego Public Health. We have had 43,000 cases since the beginning of March, and there have been over close to 1 million tests that we've performed. 3,366 patients have been hospitalized, and to date now, of those hospitalized, there have been, or also including those not hospitalized, there have been 754 deaths and 791 ICU admissions just for COVID. This map demonstrates the cumulative increase in cases. Again, as you can see, we're in the 40,000 range right now, and that we've had some sharp increases in the rate between July and August, and we're seeing that rate beginning to decrease a little bit right now. To the right here are the number of cases per city, and you can see in the city of San Diego, which is a much larger geographic region, there are over 19,000 cases within that region, and in the northern portions of San Diego, we're seeing cases of about 1,000 to 2,000 cases per city in that region, and similarly in the south eastern portions of the county, there are similar rates there. This is actually the rates by zip code, and so again, by the zip code reporting is not as isn't as robust because it's not collected as well on every patient. So the total number of numbers seen is lower than what's actually seen on the previous map. So going back to the Imperial College London, their model initially was showing that here with the black line showing what the total number of critical care beds would be per 100,000 population. If you did nothing, you can see that you'd have a very high occupancy of over 250 patients per 100,000. And then if you just closed schools and universities, that would decrease. If you added case isolations and household quarantine, it would further decrease. And then if you combined all of that, that was the blue line here with case isolation, home quarantine, social distancing, you would further improve that and begin to decrease the total critical care beds. But the red line here is the capacity line for how many critical care beds a region would have capacity to provide. And so this was really the significant concern that was occurring in March, and what we were seeing with the experience that was occurring in Wuhan and also in Italy was that there was an excess number of patients for the amount of intensive care beds that they had and significant strains on their system. When the authors showed this a little bit further, you can see that there's this blue shading that's coming across the columns. And that was to suggest what the period of mitigation would be. In other words, the period of time that you would be observing isolations and school closures and so on and so forth. And in the lower panel here, they really focused in on showing you what the critical care capacity was, that red line being at about a line of 8 patients per 100,000 of the population. And if you were able to do everything, school closures, university closures, isolation, and social distancing for a period of 5 months, you would keep the number of cases below that level and be able to better provide care to those patients with COVID-19, but also to continue to serve the patients who have other critical care needs above and beyond that. And for the most part, this is really what we've seen. We've seen that we've been able to not be overwhelmed with few exceptions. There's always a hotspot that occurs in any sort of epidemic and pandemic. And so there are certain hospitals that are going to have an excess number of care beds. Here in San Diego, we saw that occurring out in El Centro, and that there was a need for patients to be transported to neighboring facilities and neighboring counties. And similarly, with the spike that they experienced in New York, they also had a similar excess in terms of their capacity. But overall, the period prevalence has been maintained below this red threshold because of all the work that you all do, the efforts that you all make, and providing care daily and information to your loved ones, and setting by example the best practices for protection have all had a significant influence on being able to keep these numbers down and only seeing a fraction of the percentage of what was predicted had everything been unmitigated. The one caveat to this proposal here in their model is that you can see that when the blue shading stops, there's about a period of a month before the numbers will begin to increase again, and then they can spike up to the previous values that were shown there before. And it's important to note, I think, where we are right now is that we're looking at perhaps about 20% of our population may have been exposed to this virus, maybe even as up in some areas as high as 34%. But that's still a considerably small fraction in terms of those that are susceptible, and meaning that over 70% of the population, for the most part, is susceptible to still getting this illness, and therefore the mitigation strategies are expected to continue. And this is basically what they demonstrated in their modeling, was that you would have mitigation periods that were on and off, and that when they were off, the numbers would begin to increase to a certain threshold to go on again, and then we would drive the numbers down, and then we would come off again, and the numbers would increase, and so on and so forth. And this would be kind of the pattern that we expect to see. And this pattern, while it wasn't as severe in terms of the total number of ICU cases, the pattern in and of itself more or less reflects what we've been seeing on a whole. We saw many more cases in May and June, and then we began to relax our standards, and then come July, we saw a spike increase into August, and then we were seeing a decrease again. And this is just expected to be a roller coaster where we're going to see things just kind of come up and down, and hopefully we can stay away from any large spikes by continuing to institute practices when we need to. So to take a break from that, there were some interesting things that we've learned along the way. One of the things we've learned is that they've done an analysis of pets. 3.4% of dogs and 3.9% of cats actually have measurable amounts of SARS virus titers, demonstrating that they've been exposed. And interestingly enough, dogs are more likely to test positive in a household with patients in it, as opposed to cats. And I think that just generally has to do with how freely dogs like to be pet in comparison to cats. And so not a total unsurprising event here. There was a study that was actually done at the Bronx Zoo that also showed infections in the tigers and lions as well. So every now and again, we'll break it up with an interesting tidbit like this. But one of the more important aspects to look at is, well, where are we now? Like, what have we, when we started this in March, we didn't really have a lot of treatments that were available to us to consider. And there was certainly a general theme to hurry up and treat and then figure out if the treatment was beneficial or not. And I think that's certainly under an emergency like this, that's something that is reasonable to consider, and that you generally need to do something rather than do nothing. But it also leads to a number of issues of confusion with what our treatments are and what our benefit of our treatments are, and how we're sharing that information with each other. And so obviously, I'm not going to get into the politics of hydroxychloroquine and or a number of other suggested therapies that have since been proven not to be as beneficial or effective, but instead focus on what our current recommendations are from multiple organizations, including the CDC, WHO, Infectious Disease Society of America, as well as other international bodies, in terms of if you're hospitalized, what are the current treatments that are provided. So this is going to be an evidence-based review of recent trial results. Just before we get into that, I think it's worthwhile to understand, anytime you're reading the literature, and this is a difficult time because there's so many studies that are coming out, as I mentioned before. When you're reading a study, it's going to report data, and that data is going to be tested and have some sort of statistical summary applied to it. And you'll see p-values and other summary statistics to suggest if something's significant or not statistically significant. And irrespective if that number statistically means that something's clinically relevant or not, right? So that's always the crux to any good study, is you might produce something that has mathematical statistical significance, but it may not be very relevant or have very much clinical significance overall in what you're seeing. But more importantly, what often occurs, and this is something that a lot of authors don't share, and I don't know if it's just as a result of not understanding it as well, or not, but most studies that are done provide information that generates a hypothesis. They observe events occurring, and they see a statistical significance, and it creates what we call a signal, right? So a lot of studies that are being done in pharmaceutical companies and other trials is identifying, is there a signal? Is there a pattern out there that suggests that there may be an association between benefit and use of a drug or not? And it doesn't mean that you've proven that it causes it, right? And that's the big difference here. Hypothesis testing is a completely different type of paper than a paper that is hypothesis generating. And often, even in a paper that's hypothesis testing, you may have discoveries of signals during that study that actually become additional ideas that you follow later, right? So they're hypothesis generating as well. So this mixture and matching of test results has to constantly being reinterpreted with determining, is the author actually providing you something that's been tested, or are they giving you something that they're generating an idea to then follow through? And unfortunately, the words we use are very similar for these. And the statistics we use are exactly the same statistics. So it's not surprising to me that it creates a lot of confusion. And the issue that's so important about that is that if you're confused about a test result, it diminishes your confidence in the science. And if you're confused about that test result, you may be confused about how to implement that in your practice, and therefore how to communicate that to your patient. And the entire integrity of what we do and how we perform science is really been at the forefront of a lot of politicization within the current not just political realm, but in the current lay media and just general interactions with patients and our family members. And so this is why I really do think it's important, just for a moment, just to kind of tease that out a little bit and suggest that, you know, when you're looking at a study, you really need to determine, did they design the study to test a hypothesis, and are they specifically giving you an answer for that you can then share and use with your patient or not? And one of the ways to do that is being able to determine what the benefit of a drug is, and how many patients need to be treated to see an improvement, and or how many patients need to be treated to see harm. And so I'm going to take that approach as we go through the current clinical trials. And so the first study that we're going to cover is dexamethasone use. And so dexamethasone in hospitalized patients with COVID-19. This was a preliminary report from a group of UK investigators on the recovery the recovery collaborative group. And what they did is they did a study looking here that they reported of 6,000 patients. The patients were randomly assigned to either receiving dexamethasone or usual care. And they did this in a 2-to-1 fashion, meaning for every 2 patients in the usual care package, one of them was getting dexamethasone. And so the average age here was about 66 years in the dexamethasone group and 65.8 in the usual care group. You can see that the overall distribution had a higher number of males in the patient than females, and that the important portion here is the median number of days since symptom onset before they began treatment was about 8 days to 9 days after having symptoms, but only 2 days after being in the hospital. So once they were in hospital, they were fairly quick to start the treatment, but most patients delayed presentation until they were sick enough that they needed to be hospitalized. So it makes sense, but it also just lets you know that there's that you're behind the clock a little bit when you're starting to treat for this. And so with that being said, you can also see that patients that were entering the trial, most of them were receiving oxygen. 61% of them were receiving oxygen therapy, and that makes sense. That's why they were being admitted to the hospital to begin with, is that they had an O2 requirement. And so, whereas only 15% were intubated. And so, sorry, going back here for just a moment. 1 second. Okay, sorry. And so they also then looked specifically at these groups independently of what sort of baseline care they were getting. Again, here to the right side of the column, you can see number receiving oxygen. No receipt of oxygen was 1,500, 4,000 getting oxygen, and 1,000 getting mechanical ventilation. When they went to look at the actual benefit, they found that of those that were being ventilated, so on ventilators, I should say, there were 95 deaths of 324 patients, and those that were receiving usual care, there were 283 deaths out of 683 patients. So the mortality rate, this is at 28 days, was 29% mortality amongst those getting dexamethasone, and 41% and those not receiving dexamethasone. So there was a significant improvement based on the use of dexamethasone. For those patients that were getting oxygen, whether it was through nasal cannula or through positive pressure ventilation, the rates of mortality were 23% versus 26% for those that didn't receive this. Again, there was at least a 3% drop in mortality by using dexamethasone. And so those two groups are the more severely affected groups with the disease. And so it certainly it was reassuring to see that there was an improvement in the sickest groups. Interestingly, though, for the patients that were admitted to hospital who didn't have an oxygen requirement, those receiving dexamethasone were more likely to die. There was a 3% increase likelihood of death for being treated with dexamethasone. So while overall there was a significant improvement in giving dexamethasone to the COVID-19 patients, there was an important distinction to be made that it should be avoided in patients who don't have an O2 requirement, and because it's associated with harm. So when they looked at those outcomes again, the 28-day mortality rates were 22.9% in the dexamethasone group and 25.7% in the usual care group. So again, we had at least a 3% reduction in mortality by using dexamethasone. And then we found that there was a higher proportion of patients that were discharged from hospital as well as a result of that. And significantly diminished amounts of mechanical ventilation of those treated with dexamethasone, 5.7% versus 7.8% in the usual care group. So when you look at this closely, this is for all the participants. So this is for the 6,400 patients that were brought into the study. And within the first week, there's very little difference between the two. Both the curves overlap each other, and the mortality rates are both approaching 10% within 7 days. And so I think it's worthwhile to understand that, because steroids typically don't have an immediate effect. It often takes 12 hours or longer for a steroid to begin having an effect, and that effect may be somewhat muted early on. Whenever you're taking any sort of drug, in general, you need 4 or 5 doses of that drug and before you reach a steady state of concentration in your bloodstream and have a steady physiologic effect from that. So for a drug that's being taken daily, and the dosage here was 6 milligrams of dexamethasone. That's whether it was given intravenously or orally, that was the dose daily for 10 days was the prescription for this. And that has an equivalent dose in terms of prednisone of 40 milligrams of prednisone if you were to draw a comparison between them. So 40 milligrams of prednisone is the same thing of about 6 milligrams of dexamethasone. And again, within the first week, there's very little difference. Well, it takes 4 or 5 days before you get a steady dose of dexamethasone concentration within your bloodstream. And so that may be why we're seeing somewhat of a delayed effect. But there also is another issue that when patients are presenting, they're not all presenting at the same time with how many days of symptoms they had. This is why it's important to kind of think of this curve and count back 8 days and realize on average, most patients showed up after 8 days of symptoms. And there was variation between that. So for some of those that presented much later, they may have been much sicker at presentation. And there may be very little that can be done for those patients. So I think it's worthwhile to at least understand that concept that, maybe for half the deaths that we're going to see from this disease, it may be that half the deaths are deaths that we are unable to change the trajectory of the disease enough with any specific treatment or expectation from one specific treatment to make a difference. And that even when we combine our complete knowledge and best practices and everything else in this, we may still be left where half the deaths are unavoidable. And then perhaps we can decrease a percentage of the other cases that will continue, because as you can see here, from day 7 forward, whether you're in the dexamethasone group or the usual care group, you're still going to double the death rate from where you're at that point by the time you get to 28 days. Again, the difference is seen here for those that, of the 1,000 patients that were on ventilators, you can see there's a much greater significant improvement in mortality reduction, right? Where we've got in the usual care over 40%, and those that are in the dexamethasone group are in the 20s. And so very significant improvement here. Again, at 7 days, not much of a difference. And again, this is where we're seeing that it just takes a while for the drug to come on board and have an effect and be associated with improved outcome. This is the group that received oxygen only. This is the group that's getting O2 through nasal cannula or through a positive pressure ventilator. And again, there's improvement in overall survival in the dexamethasone group. However, when we looked at it in patients who weren't receiving oxygen, so that's 1,500 patients that were studied here, dexamethasone was more likely to be associated with patients who died rather than the usual care. And so this represented a number of patients that were needed to harm. And we could see that we see a difference begin to occur after about day 10 to day 11 in the observation period, that the death rate started to increase in that group. And that may be related to adverse effects from steroids in patients who don't have the same degree of inflammation and cytokine responses to them. It may also increase the rate of thrombosis that can occur. And we know that one of the things we're seeing with COVID-19 is an increasing rate of thrombotic complications. I've talked to a number of different pathologists, including one of the San Diego coroners who's had 20 years of experience, who let me know that she is frequently seeing evidence of thrombi in the organs of COVID-19 patients. And similarly, I've got a friend that's a pathologist that specializes in kidney pathology and has noted a large amount of thrombus that's seen within the arteries of the kidney in COVID-19 patients as well. So the authors of this paper didn't give a strong explanation as to why this was occurring, but I think as we've learned more about the effects and the long-term sequelae from COVID-19, that we know that that's a potential risk factor. So that pretty much covers that initial study on steroids. And so you can see this was at least a randomized trial. Throughout this trial, patients were also getting randomized to receive other treatments. So this wasn't just one treatment versus none. And the usual care here included patients that were also getting other medications, and even early on in the trial, some patients that were getting hydroxychloroquine. Great. So then the next tidbit of trivia information is some of the studies that have recently come out have looked at spread of COVID and what are the different activities that can increase spread. And one of the ones that can is singing, playing brass instruments, and wind instruments. And so this is just a recognition of what are the types of events that can lead to spreading. And what they found was, even amongst those playing brass instruments, it was really those that were playing horns, that playing a trumpet was much more likely to spread as opposed to playing a tuba. Tubas don't spread as much as the trumpet players do, or as the oboe player, or bass trombone, which generate more aerosols than speaking. And that listening to light music in a crowded environment, indoor environment, that is a particular risk as well. All right. So the next article. Sorry, I'm just going to break here just to see if there's any specific questions that have come up yet. I apologize for the loud background noise. I'll see what I can do to try to fix that.
Dr. McGlung, we had one question that said, if a person has a presumed immunity after being infected for 3 months, are they still potentially able to transmit disease?
Right. So in general, they shouldn't, because the active disease should be mitigated by their own plasma concentrations of antibody. So then the number of viral particles that may be circulating at any one time should be relatively low enough that it should be difficult to transmit. from that, assuming that they're not sharing a needle. But otherwise, I don't think that that's as much of an issue. The issue on that is that to determine if the antibodies that are present are of a sufficient quantity to be protective for you, and we're going to get to that in this next article. Cool. So the next article is the effects of convalescent plasma on mortality, and this is, when you see an article published like this, it means that it's in preprint, meaning that it hasn't actually made it into the print in the journal yet, but was shared early. And so this is a group of researchers across the U.S. And include some research and include many from the Mayo Clinic that helped set this up. Palomar was actually a participant in this study as well and contributed patients to this. So this study was of 35,000 patients that received convalescent plasma. And early on, when the idea for this started, in general, the way that we practiced changed. And so it's really important here to kind of highlight that for you, because it almost can't be overemphasized. Let me see if I can move this screen a little bit. There we go. So the study started in April, and so they broke it up between the first month of treatment, then the next month of treatment, and then June to July. And then they froze the data at this point to then look and study it. And so you can see that in April, there were 5,000 cases of severe life-threatening COVID that were included. In May, that had doubled to 9,000 cases, and stayed about the same in July with 8,000 cases that were there. And the important part of this was that when we first started using plasma, we were using it as a compassionate use, right? So like we were using it in patients who were the most severe, and it was sort of like throwing the kitchen sink at somebody who was extremely ill and deciding to get those patients on plasma. And I unfortunately had a friend from med school who died from COVID-19, and she was practicing back in New Jersey. And I remember the emails that we were getting at the time updating us about her course, and the sudden email as things had, she'd already been admitted to ICU and intubated and so on and so forth. And after a day or two, then getting an email requesting anybody that knows somebody that could donate convalescent plasma. And so I think back on that and think how much she illustrated the type of patient in April that we were treating with plasma. And you can see that in these numbers here too. Again, the severity, and from a percentage standpoint, 80% of the patients that were receiving plasma were severe cases. And then by May, we began to include additional cases that weren't maybe as severe. And so now 65% of the patients were severe. And then by June and July, we continued to relax that standard. And now it dropped down to 60% of the cases were life-threatening cases. And so this is an important aspect to be able to look at of how this influences a study protocol as it's being actually operated. Because if you're including patients that are less severe, then you expect similarly that their mortality rates should be decreasing over that time period too. And because you're bringing in double the number of patients in that same time period, you may assign benefit to a drug when in fact what it was a different recruiting standard. You operated differently in that period. And this is why it's important to understand these studies in a far more detailed manner than just, oh, if I give plasma, patients do better. Like I wish practicing medicine was that easy, and I wish reporting this type of information and sharing it was that easy, but it just isn't. And so the reality is that we need to understand these studies in detail so we can really appreciate what we're doing, and being able to communicate this to patients and let them know, and their family members to let them know what's the likelihood that they're going to survive given these treatments and what our best practices are. So again, Similarly, down here at the bottom, you can see that the number of severe risk factors was none in 20%, and then it was done in 34% and then 39%, right? So again, less severe patients were being included in the study, and this was 5,000 patients added here and 5,000 here, which is just as much as the first grouping here. So important to kind of see that. Now, the next slide looks at additional drugs that patients were receiving, right? So again, in April, 53% of these patients were receiving steroids, and only 4.7% of them were getting remdesivir. And you can see here, 62% were getting hydroxychloroquine, right? And then as the study continues, by June and July, only 1.8% of the patients are getting hydroxychloroquine, because by this point, we'd realized that not only was it not a benefit, but that it was a potential harm in all the QT prolongation and cardiac dysrhythmias that were being associated with it. And again, you can see here the steroids stayed more or less about the same in terms of their use. And remdesivir, as the initial report started to come out of its possible benefit, by the time we're in June and July, 46% of the patients are now on remdesivir that are also receiving this. So again, we have treatments that we're seeing an increased use of that may have benefit in these patients as we're doing this, and we're bringing in patients that are less severe. And so it's a bit dizzying to try to tease out what's occurring because of that. And then we got better with the way that we practiced. Initially, the amount of time to transfuse plasma, the majority of patients were being transfused after 4 days of hospitalization. And so only 22% were transfused in the first 1 to 3 days. And then that became 38%, and that then became close to 50% of the patients by the time that the trial continued. And so it's going to be an important aspect to consider: when are we treating people and how quickly are we treating them when they show up to the hospital, to then expect whether or not there's going to be a benefit. You know, we've often seen a number of different cases over the years in patients who are very severe that giving them a treatment makes it difficult to change the trajectory of their disease when you give it at the last moment. All right, and anybody who's worked in an ICU knows of a number of different features that we kind of talk about, medications that are given to somebody, and we kind of almost say that they're being given those medications as the last rites. We often see the medicine being given with little or no benefit because those patients are on a trajectory that seems to be insurmountable and unable to change. Again, when you look at plasma, it comes in a bag like this, right? And the issue is that convalescent plasma and the effects that COVID has on one patient to another, and the number of viral particles that are produced and the number of antibodies are produced, are all dependent upon the stage at which the plasma was drawn. How many weeks after a patient had had disease was it drawn, and whether or not that person's immune response is one that produces a high concentration of antibody or not. And so I'd say that this is kind of similar to looking at a glass of beer. By just looking at the glass of beer, just as we would a bag of plasma, you can't tell if it's going to be like an O'Doul's of 0.4% alcohol by volume, or be in an average range here of 5% to 6.8% with these beers, or if it's going to be a super concentrated amount of antibody that's present, like this 10.8% volume of a Stone triple IPA. And so, so the plasma that's being given is being given at a certain time frame. And as the trial went on, we got better about giving it sooner. And at the same time, they were able to later measure what was the concentration of antibody in the plasma that was being given. So they divided this up into different categories here. Down here where it says ortho IgG, you have a dose response of low amounts of antibodies, a moderate amount of antibody, and then high doses, right? And high amounts of antibody. And so they could see a dose response that improved here. Patients who received a low amount of antibody had a 13.7% 7-day mortality, versus those that had a high percentage of antibody had an 8.9% mortality, right? So there was a significant improvement here. There was at least a 4% drop in mortality by getting a high concentration of antibody in the plasma. But again, you don't know this when you're giving it to the patient. So all you get is just this bag without knowing what the concentration of antibody is within it. And so this began to then look at, well, what were the effects longer out, right? So 13% of the patients were dead within 7 days of receipt of their antibody. But within 28 days, that number grew as high as 30%. And those that had a high antibody concentration had a significantly lower mortality rate of 22%. So again, about an 8% decrease in mortality by giving this then. And then they looked at this even further and said, okay, well, what if we look at this not only by the concentration, but by how quickly we gave it? And when they looked at how quickly they gave it and doing it within 3 days of a high concentration, they dropped the mortality rate down to 16%. And so that in and of itself is an important finding to be able to look at. Now, what's really important to understand here is that this is not a clinical trial in which patients are being randomized to being given plasma versus nothing, or plasma versus placebo, right? They are receiving additional treatments. So they're receiving remdesivir, they're receiving steroids, they're receiving other therapies during the course of this study. And this is one of the difficulties of a study when you're reporting a study like this, is because you're not as controlled, and it's harder to tease out what is the true benefit. So really what we're able to do is look at this and say, well, what's the lowest we can maybe get the mortality rate down to in a group of patients that have COVID-19 and are hospitalized. And if we can get down to these types of numbers of 16%, then that's probably the benchmark we should be trying to aim for. But again, recognizing that most of the antibodies that are out there aren't of that, most of the plasma rather isn't of that concentration. Most of it is here in the moderate group, right? So perhaps a reasonable benchmark for hospitals to consider is trying to keep their mortality rates to 22% or lower, and aiming for this, but realizing that if you're within this range, you're probably in the average range of experiences for the patients that are hospitalized, and that after a month later, that potentially 1 in every 5 patients that were hospitalized may not survive. So again, they looked at this closely, breaking these groups up into 7-day adjusted mortality. So they were controlling for a lot of other effects. And in doing so, they found that if you treated with a higher concentration, you had lower rates of death, 10% versus 14%. When we then come down to the next slide, this is again 7 days, and this is looking at, well, we can get it down to 7.6% if we do this within 3 days of treatment. But the further you went out, once you started treating this more than 4 days out, you were losing the benefit. So there wasn't quite as much benefit or as much change seen between these. You see that there's an observation of it, but statistically it wasn't significant. And then we looked at this again at the 30-day margins. And at the 30-day margins, things are more muted because you still have a progression of disease in patients even when they're receiving plasma. And so the rates were 24% deaths in those that had a high concentration versus those that are 29%. One of the other kind of key features, and we saw this again, same thing where there's more of a benefit if you treat early. So the authors really kind of helped demonstrate that. And then they broke it up into patients based on how severe they were when they entered the hospital. If they weren't on a ventilator and they didn't have any other significant risk factors, they had a significant improvement in benefit here. If they were treated within 3 days compared to if they were treated in 4 days. If they had some risk factors, suddenly, right, if you have hypertension, heart disease, COPD or something else, your benefit is still observed, but is not significant and not as beneficial. And if you have many risk factors, we saw that those patients didn't seem to benefit from plasma as much. And then again, when we looked at the ventilated groups, so these are the patients who are intubated. If they're treated within 3 days, they did much better in comparison to those who are treated 4 days. So overall, after controlling for a number of different factors, they found that delivering plasma to patients resulted in improved survival, and it was statistically significant. And this is why plasma is being suggested as a current treatment for patients. One of the other aspects that they did is they decided, well, if we looked at this differently and tried to create a study where we were trying to do plasma versus placebo, why don't we compare the high concentration versus the low concentration and skip the middle for a moment and just see as if this was the placebo group and this was the group getting treated. And so they broke out and did a study like that. And when they did that of high concentration versus low concentration, they found overall there still was an observed benefit, but the benefit was about the same. It was about the same size effect of what they observed for all comers here. So you see here, this is relative risk of 0.65. So there's relatively a relative reduction of about 35% reduction in relative death rates. And here it was a 23% reduction that was seen. So this study for all intents and purposes, not a hypothesis testing study. This is a hypothesis generating study. It generates the hypothesis that antibodies, if they're in a sufficient quantity and concentration, may be beneficial and provide better improvement in outcomes for patients. The degree that it does would be better determined through a placebo-controlled trial. But now that this data has been shown this way, it may be very difficult to actually design a trial that way, because it may be perceived by the patients that it's not, having seen these results come out or have listened to the reports in lay media, they may be less likely to consent to be in a trial like that. And so we may never know the true benefit or potential harms with giving plasma, but at least to date, we can see that there has been a significant reduction in mortality, and perhaps we can get mortality as lower than 22% by doing this type of treatment. All right, are there any questions about plasma?
So Dr. McGlung, we have one question about plasma. How would a physician go about getting a hold of the higher concentration plasma?
Right. So the point of that is that we don't know, right? So the amount of ramped up testing that would have to be done to be able to determine that isn't really feasible, right? Like it's hard enough for us to keep up with being able to just run COVID tests on patients, as you all know. And the daily issues with supply chain issues with whether or not we have enough reagent. And then when we do have enough reagent, do we have enough swabs? And then if we have enough reagent, enough swabs, do we actually have, enough machine capacity to run the studies, right? So this issue of being able to measure the antibody concentrations requires a research laboratory that has the ability to do that, and that's not going to happen. I would say that the answer to this and what you're seeing in industry that's occurring is that instead of trying to get high plasma concentrations, is to make synthetic antibody and produce that as an alternative. And again, that may be an issue where we're able to see a randomized trial because it's a synthetic, and the synthetic has to be studied in that way. So there may be an opportunity to do that, because obviously the patients who aren't getting the high concentrations aren't benefiting nearly as much. Their rates of death are significantly higher, and particularly when they're given it later in their disease course. And so it's a significant challenge, and that would be one way to answer that. The only other way to answer that is that we may become more knowledgeable about a better time to harvest plasma from patients. And as we become more knowledgeable about that, we may therefore also include a higher proportion of higher concentrate into the public just by doing that. And so, there's always ways to find solutions. And it's just a matter of trying to be clever about taking the information from studies like this and then apply them to what we can do with mechanisms that we already have in place. All right.
There was one other question, Doctor, about whether or not the incident numbers that you were referring to earlier in the presentation, whether or not they had been compared to the 2017-2018 flu season.
I haven't done a direct comparison to them to lay them side by side each other, but they're nowhere near each other. I mean, it's the numbers that we're seeing in COVID cases eclipses everything that we've seen from any flu season ever before. Not just in terms of the number of cases seen total within time period, but the death rates that we're seeing, even with the H1N1 virus. H1N1 didn't have particularly good treatment for it. Tamiflu didn't have any effect on mortality for H1N1, and it responded better to ECMO than this virus does. But the total numbers are nowhere near each other. We're looking at 40,000 cases of flu last year, maybe 60,000 cases of flu last year, and deaths that may have been related to flu last year. And those numbers were like the 40,000 was already considered a high projection. 60,000 was the upper limit of the model that was aggressive. And obviously we've eclipsed that in the number of deaths that we've seen with COVID-19 so far. All right. Another point of trivia is that it appears that toilets flushing can also can lead to massive upward transport of virus particles. So there was a study that came out where the authors suggested protecting the lids against the spread. This next study, I realize we're running low on time. I'm going to go through this quickly. The remdesivir study is a study that came out as a preliminary report, and the safety monitoring board that was monitoring this stopped it early because of what they perceived was a benefit, where one group had a lower hospital length of stay than another group. And so before seeing whether or not it actually improved survival, they went ahead and stopped the trial and froze the data to report. So there were 132 people receiving the drug who we don't have data on in terms of outcomes, and we have 169 in the placebo group that we don't have outcomes on. So this data is still yet to be fully reported by the pharmaceutical company, and there's a little skepticism that I have about that. But all in all, what they found was there wasn't really any significant survival, a statistically significant survival benefit in those receiving remdesivir versus those that didn't, but they did leave the hospital sooner. So when we looked at one group in particular that there was a mortality difference, it was in the group that had required supplemental oxygen but didn't require mechanical ventilation. And in that group, for some reason, the placebo group had a much higher death rate. In fact, their death rate was just as high as if they were in a very severe intubated group. And so I don't know if that specific group in this kind of comparison really overemphasized the authors overemphasized the study coordinators to stop the study or not. But it certainly wasn't observed in any other grouping in terms of receiving the drug versus receiving placebo. And so of the 1,000 patients that were recruited, 500 and a little over 500 in each group, they found that patients stayed in hospital and had a recovery time that was much shorter. So the recovery time was 11 days versus 15 days in the placebo group. And that while they observed that there was better mortality in the group that received remdesivir, 7% versus 12%, it wasn't actually statistically significant because they didn't recruit enough patients to meet that level of reporting. And when we looked at it more closely, we saw that the group that actually benefited from remdesivir is the group that received no oxygen or received some oxygen, but not in the group that was sicker. The groups that had any form of high flow nasal cannula or positive pressure ventilation versus those who were intubated had no benefit from remdesivir. And so the only true benefit that we're really seeing is that it gets patients out of hospital sooner. And that is not an unimportant issue, particularly when we're looking at those initial models where we're concerned that ICU capacity was going to be overwhelmed. So the benefit of remdesivir may just be that it reduces total length of stay within the hospital, but it's not necessarily expected to reduce the length of stay in the intensive care unit, right? Because the patients that are in the ICU are generally the patients who are on ventilators or who are on high flow nasal cannula or BiPAP, and therefore we may not necessarily see that much of a benefit. And because this study was stopped early, and we don't have the full report yet, I'm suspicious as to whether or not we're going to see an even more muted response in the data as it comes out. And these are patients that were receiving remdesivir for 10 days. There has been a study recently reported looking at 5 days of treatment and seeing improvement. And so a similar improvement in length of stay, I should say. And so the Infectious Disease Society of America has come out with a recommendation where patients that are admitted and are sick should get 10 days of treatment of remdesivir, and those that are less sick but admitted to hospital can get 5 days of treatment and receive the same benefit. And so that brings up the issue of what the quality of the evidence is for all these studies. Overall, the total quality of these studies is not fantastic, and it's not obvious. But we're early on in a disease process, and the data is coming at us quicker than we've ever had before, and we're lowering our standards for when we begin to institute a therapy. And so this is on the stuff that works. So the point of sharing that with you is that in the things that we're adopting and we're actually using, this is the best evidence that we have, and we have so much more to learn about this. And as we do, we'll be able to hopefully refine our practice and continue to share our experiences to look at other types of therapies and treatments that our patients may benefit from. Lastly, there's just the issues of testing. We've all now become experts in learning how to test, and realizing the deeper you go towards to the respiratory tract, the better the sensitivity is for testing. But with antibody testings coming out, there's a good study here that basically just demonstrates, and this is important for the plasma issue, right? That the antibodies come up as the virus begins to dissipate and you survive, and then your viral loads begin to decrease, and so your antibodies will actually begin to increase here this is IgM that comes up first and IgG that comes up next. And so the concentrations, if somebody suddenly recovers within the first 10 days, we may not have very much antibody that's harvested from them. And if they're going back and giving monthly amounts of blood for donation, by the time they're out over a month, the amount of concentration of the antibody may be significantly decreased. So if we're going to try to get high concentrations of antibody, then we're looking at trying to get patients in sort of like this 15 to 20 day window after symptom onset, so that this way we're trying to harvest at these peak periods of time. And so that's the one aspect of looking at these other studies that are looking to see how sensitive are these tests that we can kind of learn from. And then what's our most effective treatment? Our most effective treatment is prevention, significantly. All right, so this is the improvements and decrease in infection rates based on distance. So this is the 2 meter rule, and seeing how significantly you're actually able to decrease the absolute risk based on distancing. When you look at looking at N95 masks versus no face mask, the reductions are incredible. These are reductions far greater than anything that we see in any current treatment that we have, these risk reductions. And when you add eye protection to that and wearing a mask, you can see that you also get similarly improved outcomes by adding eye protection. And so again, this is why it's not surprising that some of some of the current comments that are coming out of the CDC are that face masks are better than vaccines because we don't have a working vaccine yet, and the face masks are more effective than any other treatment that we have. So prevention, truly an ounce of prevention is worth a pound of cure, and this is our best aspect of mitigating this disease until we get better treatment options and our vaccines. American College of Emergency Physicians came out with a brief report here that basically uses a method to discriminate and determine which patients should be admitted, where they should be admitted to. It's a bit of a complex algorithm to go through, but all in all, there are a number of different labs that we're measuring, and if they have any abnormalities in these severe lab categories, not only should they be admitted, but they should be rounded on quickly because this group may be at particular risk of progressing and becoming critical and requires more attention. And so there are a number of different ways that we can kind of categorize if somebody's at mild risk of progression, moderate, severe, or critical. But it's pretty easy when you get a critical patient to know what to do with them, right? And when you get a patient who's really not sick and they're just concerned, we know what to do with them. It's the ones in the middle that we have to kind of parse out and figure out how do we manage this better, and how do we determine if we're going to observe them versus discharge them? If they're going to come into the hospital, do they need to be in a tele unit or can they just be on the floor? And what can we do to appropriately marshal our resources for those patients? And that's what this has. This is an interactive map. So if you just type in ACIP COVID-19 severity, it'll come up and you can just click through it and it'll tell you what you should do with that patient in terms of where they can go. And then lastly, some important things that we've learned about how to treat acute respiratory distress syndrome has come up from this. And we really just learned how to carefully titrate FiO2 and PEEP on these patients and to give lower tidal volumes to them. And one of the lessons I've learned mostly was that in patients who are severely acidotic, and this is in your patients who are peri-arrest mode, to increase your ventilator rates to 35 respiratory rate. And it seems incredible to kind of increase it to that rate, but it's really necessary. When you don't do this, it's nearly impossible to turn that patient around, and they're almost certainly nearing death when they're this acidotic. And so besides just giving a bicarb drip, you really need to drive the respiratory rate up to high values. And then lastly, for your own protection, we've learned that in the use of our masks and our N95 masks in particular, when we're intubating patients and potentially having to reuse them, that after, with one full shift of use, the masks, this is the dome masks, not the duckbills. The duckbills should only be used once. You shouldn't use them for any additional shifts beyond that. The data doesn't support doing that because they don't seal as well on the second day. The dome ones, these are the ones that are generally blue in color. They begin to decrease by the second day of use down to only 91% of them being effective. And after 2 shifts of use, by the 3rd shift, you've dropped over 24% and it shouldn't be relied upon. And then lastly, here are the features just to look for again that are considered major features of COVID-19: fever, persistent cough, unprotected close contact with a confirmed case. These are major criteria. The minor criteria are hoarse voice, persistent cough, sore throat, discharge, shortness of breath, wheeze, headaches, muscle aches. Down here, this is really important. We've had a number of patients who went through screening up front and triage that come through that we discovered to be COVID patients with only presenting with GI symptoms initially. So worthwhile to remain vigilant on those cases. And lastly, these are different isolation recommendations for exclusion from work depending upon what sort of symptoms you're having. So if you have major symptoms and clinically it seems that you have COVID-19, then you should isolate at home for 7 days, regardless of what your test result is, because there's enough false negatives that you can't rely upon that, and only return to work if you've had no fever for 48 hours after the 7 days and that your symptoms have improved. Otherwise, if you're testing positive, it's obviously the same recommendations I just mentioned. If there's a medium probability of this, household contacts are and you test negative, you should get repeat testing in 48 hours. So this is, again, if there's a medium probability, it's not just to be tested once, it's to go back and get tested again within 2 days or 2 days later. And if it's low probability and you've got a negative test result, then you should relax and return to work, and unless you have, just watch yourself for symptoms. And otherwise, that's it. So I apologize for going over. But I do thank you for your time and attention. I can see a question here says, regarding 6 feet of distance plus masks at work, we're not keeping 6 feet of distance, but we're wearing masks and our infection rate from staff to staff is relatively non-existent. So is it really just about the mask? No, of course it's not just about the mask. And it's not just about the distance. The issue is because we're observing infection control practices that also include hand washing, and you're often gowning and doing a number of different things of separating the patients based on their severity. This really varies. Like when you're in the ER, obviously we work in closer contact with each other, and it's before we know what the patient's risks are, which is so much different than everybody else in the hospital, right? There's the front line, and then there's the front line, and in the medics understand this just as well as anyone else, that we're dealing with undifferentiated patients, and so it's that much more important for us to observe best practices. And while the 6 feet of distance is not being observed in the emergency department between the staff, it doesn't diminish what that effect is for the public. And so from a public perspective, it certainly is important to continue to maintain that, to be able to demonstrate an improvement in reducing the risk of spread, but realizing that that when we are at work with each other, that you're still better off distancing when you can, and when you can't, realizing that we are being protected by masks and eye covers and so on and so forth. So I would say that the masks and eye covers are a very important part of this, but just as much as the rest of your infection control practices. Great. Any other questions?
Dr. McGlung, did you get that, or was I still muted?
You were muted. I apologize.
I'm sorry. Okay, so we have just one more question, and then we'll close out for the day. Is there an average time frame from the studies that once patients get the plasma, they show signs of improvement?
Right. I'll just pull it up here quickly. In general, so this was the other issue about the study, is that not everybody received the same amount of plasma, the same frequency of days of plasma treatment either, which kind of varied. So this had a similar pattern as to what we saw with the steroid study, that in the first 7 days, you can see here that there was some improvement seen. So it's possible with plasma that we may see improvement within that time period, whereas we didn't with the other diseases. With the other drugs. So there is, we may see an improvement beginning within 4 days, maybe 3 days to 4 days following treatment, which is going to have a better effect. But again, it comes down to, well, what concentration of the antibody were they getting to actually have neutralization from that antibody percentage? And this is just the part that that we're learning about, right? Like this is a new process, new disease, and we're using an old treatment like plasma to try to mitigate this until we can actually get things ramped up and find an antibody that would actually be neutralizing and beneficial, and at the same time not cause autoimmune disease after being given to a patient. And that was the issue with the recent vaccine trial that was stopped, was that there was a case of a patient with transverse myelitis after getting the vaccine. People don't like to be paralyzed after getting a vaccine, and so it caused pause in the trial to try to make certain that, to see if that was just a observation that was coincidence, or if that was a cause, and it needs to be determined before you can safely proceed.
Excellent. Well, thank you so much. And thank you so much, Dr. McGlung, for your time. That was an excellent presentation. For all of you attending, thank you so much for coming and joining us. We're running a little bit late, so I will wrap it up. Check your email. You'll be getting a link to a survey for the follow-up questions. Please give us your feedback so we know how we did and what we can do better. And I hope we will see you all next week when we have our next presentation. So thank you again, and good night.
Thank you.